here this week. Many of y'all got the book in the back. This is going to be a short question and answer and just kind of a panel discussion. So if you have any questions, all of us can you can get in touch with us. I'm going to give you my phone number real quick because I'm not always easy to get. Maryann can always get me. She can find me. If you can't find me, call Maryann. She can get me. My cell phone number is 985-351-4502. I live out of New Orleans. I do have a very deep Southern accent and often have to spell what I'm saying. But I had the honor of putting things together for a long time for this group. But this will be my last one in a big setting. I'm a little bit old, and thank goodness we have young brains coming aboard that's going to be able to carry this train. But I want you to know I'll always be there for you. Zoom, I'm a queen at Zoom now, so I can Zoom away and I can go on short things. But this is a big undertaking, and I've loved it. I have enjoyed it without question. So please feel free to ask any questions. Feel free to get in touch with me if you have anything that you need to discuss beyond this. Thank you.
Thank you, Leigh.
I must say, so when I started my journey with neuroendocrine cancers, I was just bottom of the totem pole resident, and and she was there in our NOLA-NETS program mentoring, so I consider her as one of my mentors. Why? Because nutrition, diet is a very important, integral part of the multidisciplinary care that we give to neuroendocrine tumor. And she has been a trailblazer, amazing support, and net patient advocate. And it's just so sad. I told her, don't say that this is your last one, never say never. Just take a little break, we'll pull her back in. But so very thankful for everything that you have done for our community.
Thank you.
Maryann, do you want to? I have other two fantastic panelists. Maryann does not need any introduction, right, guys? You've seen. So Maryann, developed or co-founded NCAN, has been doing this for now decades, almost two, and she's a NET patient herself, so she will give us a patient's perspective to the nutrition and the issues and how to circumvent some of those. And our third panelist is my colleague from Markey Cancer Center. Rachel is our nutritionist there, and she is really, I am very lucky that she's there for us, because any patient of mine, and of course most of our patients have issues like short gut syndrome related diarrhea, Koyasuna syndrome related diarrhea, high-grade patients with chemotherapy-related diarrhea, right? Radiation enteritis-related diarrhea. So there are so many issues, GI issues, and she is just so fantastic, very, very passionate about what she does, and spend a lot of time with the patients, and also is involved in advancing our understanding and science. So she was very instrumental. In fact, the key part of the ENTRADE study that we did, and so really, really grateful to have such fantastic high caliber speakers here. So this is going to be a very laid back, relaxed panel discussion. We would open the floor to questions, but just to kind of set the mood, I would like to first start off with a very basic set of questions so that we cover most of the broad topics, okay? And just like you, I would also be learning about some of these aspects. So it's a wonderful opportunity for me to be here. Leigh, let's start with you. Why do we need to know about nutrition and diet? What is so special about neuroendocrine tumors that we have to have an understanding of what to eat, what not to eat?
Well, one of the biggest things that we're preventing in nutrition with this, and as well as other cancers, this one's very unique, is that if we don't watch it, and we know that there's a high incidence of malnutrition, it means you're not absorbing nutrients correctly, and your body's not absorbing, then you're going to be depleted. Okay, we know there's a lot of deficiencies that are associated with this in the long run, but it creates the environment that your body may not be able to utilize those great medicines and all the treatments we have. So it has to be part of the plan. If you cannot get your nutrition correct, it's real hard for these treatments to work for you. So that's one of the big things, is we want to prevent malnutrition, what we call involuntary weight loss, muscle wasting, and fatigue. That's kind of it. We work on quality of life. That's what we are. We're quality of life people. So.
It is completely paramount, no matter, for example, for my high-grade neuroendocrine cancer patients, one of the advice I tell them, hey, my chemo is only going to help you if you're fit enough to tolerate the chemo. How would you get fit enough if you do not have a good nutrition? So they're very integral part. Our surgery colleagues, Dr. Lou, right? He will not operate on you if you're not nutritionally optimized, because the healing, the recovery, everything depends on your nutritional status. So it's really, really important so thank you so much for that. My next question is for Rachel. So let's get into brass tacks here. Carcinoid syndrome. What would be some of your, how do you counsel carcinoid syndrome patients with a lot of diarrhea? How does that visit look like? What are some key take-home messages from nutritionist standpoint for carcinoid syndrome patients?
Okay, when I meet with folks in the office, I kind of do an assessment. So I do look at some of the things that Leigh was talking about. Your weight, what's your nutrition status when you come to us? And what are your symptoms? So I'm the second or maybe third person that comes in the room and asks you how many stools you have a day. And so I could kind of get an idea of where we are. And also starting really with the individual. How severe is the carcinoid syndrome? How often are you having these symptoms? Do you personally identify any foods that are a trigger? And sometimes you may say to me, it doesn't matter what I eat, it seems. So I kind of, that, because I do hear that a lot. So I will look at, the typical aggressors, and because we talk about, normal diarrhea, but your diarrhea is not typical diarrhea, right? So we talk about the things that may aggravate the situation, but then we really work to start with a blank slate and figure out what's going to work best for you. So we're not looking at a giant list of no foods, because they're not no for everyone. And looking at that and kind of, and it takes some time, and so I do try to remind patients of that as well.
Wonderful, thanks. And we will get into some specific foods-related question in a bit. Maryann, next one for you. Now, you've been a NETS patient for several years, and you've kind of publicly acknowledged your journey with carcinoid syndrome, diarrhea, and you've tried a lot of different treatments as well. So you can give us a very good patient perspective to it. What were some of the challenges, and give us some advice how to circumvent those challenges?
I think that's really important is that you keep a diary, like a week before or 2 weeks before you go to the doctor. Keep a diary of what you ate, how many times you went to the bathroom, what was it like. Because, like I said downstairs, if anybody was downstairs, when you get into that office and that doctor walks in, everything goes out of your mind. And I am the #1 guilty person. Robert will testify to that. When the doctor comes in, I'll say, no, I'm fine, yeah, the diarrhea is not that bad. And Robert will be like, you were in the bathroom 20 times the other day. What are you talking about? And I was like, well, it just happens, because I think that a lot of us, especially with carcinoid syndrome, we are so used to going to the bathroom all the time, you don't think about it. You don't say, hey, I went at 9 o'clock, I went at 10 o'clock, I went at 12 o'clock, I went at 2 o'clock. You don't think about that in the middle of the night. How many here get up in the middle of the night to go and have diarrhea? And so a lot of times, that's how the doctors are able to tell, from what I understand, is that if you're waking up in the middle of the night with diarrhea, it can be related to carcinoid syndrome. If you don't eat and you're having diarrhea 10 times a day, 5 times a day, that could be carcinoid syndrome, and you need to discuss that with the doctor. Because, even with, when you're prepping for the test and things like that, you're still in the bathroom, then obviously there's an issue. But I think that it's really important that you do keep a little diary. I'm not telling you every single day. I'm talking about just at least a week before. So this way we know. Triggers can be anything. Some of us triggered by, like I said, turkey was my biggest trigger. So really write down exactly, if you had a salad, what was in your salad? Did you have tomato? You know, there's that list, that 5-HIA list. You know, everybody thinks, oh, you have to stay with that all the time. That list is made as a guidance, kind of, for you, and not a no-no list forever.
Let me step in on that a little bit. So I've been doing this since 2002. I told you I was old. And initially, sometimes you have the best intent and things get kind of out of whack with what you intended to do. So one of these things that were all very, very common is when I first was asked to do this, first of all, there was no books on what to do with carcinoid. Okay, there just wasn't, syndrome, just wasn't there. So I had my way of doing it, and many of you may have picked up a book, Finding the Food You Love, out there. Well, I wrote that book, and I did it the way I teach, to try to get people to realize that if you don't have problems with something, you don't have to change your diet. When we first did these restrictions in carcinoid syndrome, when we went out and introduced this through pharmaceutical, they really wanted us just to hit carcinoid syndrome patients. That's why we put the information out. But over time, it transferred that everybody that had neuroendocrines thought they had to have those same restrictions. So remember, you don't restrict unless you're affected by it. Otherwise, we really want you to have a really round, balanced diet of things you enjoy. We try to get a rainbow of colors. We try to base it. But many of the things that we taught and we explain are really come off of, believe it or not, the old brat diet. How many of y'all heard the brat diet? So we took soluble fibers, things that were easy to absorb, and we took things that we did for different diseases, right? So we kind of went down to the basics of what everybody can kind of do and then built it up. But I don't want people to think that if you see those guidelines and you're not affected by flushing and triggers, stick to a really nice diet, okay? Okay, it's not, you only have to restrict. We worry about food avoidance. That's our biggest problem with patients, is weight loss and food avoidance. So remember that when you get to
Yeah, and don't forget, everything moderation, okay? So you see all these guidance, avoid this or that. You're absolutely right. If it's not bothering you in a reasonable amount of quantities, good. You don't really have to. So my next question to Rachel, what are some of the common myths that you've heard diet-related? Should patients starve? Intermittent fasting, can they kill cancer? Stuff like that. And what is your take on those things?
There's a lot of research into nutrition and its relation to cancer. A lot of that needs more study. It's not a current protocol to say that we do intermittent fasting. I think we need a lot more research on that. I think that patients, what I've seen, and understandably want to do everything that they can to help themselves. They don't want to do anything to harm themselves. And I think part of my job is being able to explain that to patients and kind of let yourself off the hook, because it becomes very easy to worry about it so much that affects your quality of life. So there's lots of myths, or there's lots of really unproven diets that could even be harmful, honestly. So that's why you should always ask. I mean, the internet is the internet, and so I, try to help guide people through a lot of those things. There's everyone asks this all the time: does sugar feed my cancer? Well, it's not exactly that. It doesn't work that way. I try to explain how we use energy and how the body cells use glucose as a form of energy, and that's how everything works. Everything that we eat is broken down for the most part into that glucose, and so regular cells use our glucose. Cancer cells use glucose, but it's not that direct. So if you eat whole grains and you have fruits and vegetables and all the clean things, you're still going to have that cycle of glucose for energy uptake in your body. So it's kind of back to moderation. You may have dessert. You may have, as long as that's something that's part of your quality of life, it's within reason. we don't tell anybody to avoid that. We don't tell people to avoid dairy unless we're trying to mitigate some of your symptoms and what you're experiencing with treatment. But the list can go on, but that's kind of some of the things that I am asked a lot.
One thing we do see with the sugars, I'm going to add on to that, is that sometimes in patients, especially if they have a lot of diarrhea, the concentrated sweets in fruit juices and things like that, and we put into literature to avoid concentrated sweets. And concentrated sweets, as a definition, is, if you were looking at the labels on the back, it would be greater than 12 grams. Okay, the concentration, in case anyone's looking at that. But the reason we did that, because it causes, especially people with gastrectomies and different cancers, it causes what we call dumping syndrome. And so with that, that's kind of what we watch those things for. So when you see that, it's usually the juices, because they're concentrated. Remember, apple juice has a real high osmolality, it has a lot to it, and it's can really cramp your stomach. So that's really what we were watching for. And so anytime, you can always have a half a cup of juice is under that 12 grams. So we never mean don't have anything, so remember that. So it's all a portion size. So we can fit any of those things into your diet. Many times it's just the portion size that we allow, and we may space it throughout the day. It's about 6 times small amounts, so, all right.
Maryann, I have a question for you. Do you see lack of access to a nutritionist as an issue among the patient community? I know in academic centers it's easy, but how accessible are dietitian in let's suppose out in community, and should they be part of our routine care?
I believe so. When I got diagnosed, Monica Warner was a registered dietitian, and she was doing a lot of work on coming up with ways to help the patients with their nutrition. And unfortunately, in 2009, when she passed away, a lot of that stuff was gone. And thank God for Leigh, because she kind of jumped in and helped us. But we don't have a lot. We really don't. We only have a few nutritionists that actually know what's going on. And we actually had an event in Nashville for lungnoids. And this is why I don't have the nutritionist talk before lunch.
Or before the rest of the meetings.
For the rest of the meetings. Because, these events are very costly. So once in a while, we do have to put a cold cap platter out to save a little money. And this woman came in, and she really didn't know anything about nuts. And she came in, and she said, absolutely, never eat a cold cut. It'll kill you. Well, we're at the Vanderbilt Hospital, and their cafeteria was supposed to be open, and at the last minute, it was closed. So the closest thing to us was Panera. So Panera sent over platters of cold cuts. Now, before anybody says anything, these were lung patients, that most of them don't have carcinoid syndrome. So now we have 100 people coming out saying, are you trying to kill us? I said, what are you talking about? They said, you're serving cold cuts. We're not allowed to have cold cuts. And I'm like, one day is not going to kill you, number one. I said, number two, we weren't expecting this to happen. It turned out the hospital closed. I'm sorry. But that's why yesterday we had the cold cuts and not today. But, everything is really...
How many patients are we missing? I'm kidding.
But, everything is in moderation,
And let me take a little clarification. So one of the things on the cold cuts, now that we've opened up that Pandora's box, is that we worry about people with suppressed immunity. If your immune system's low, if you're going through chemotherapy and your white counts are low, you can't fight infection quite as well. And foodborne illnesses is one thing that we do concern with in oncology across the board. And back in the day, we didn't do a lot of chemotherapy, especially when I got into this. So we could pretty much use anything we wanted to. But if you were going to do a cold cut, the only thing you want to do is we would just want you to put it in the microwave for about 30 seconds and steam it, and just kill that little bacteria. So you can even do that with deli foods, anywhere you are. Usually we can find a microwave or we steam it. And a lot of times these facilities know that. and we work under real stringent guidelines. I now even work in nursing homes back again. I consult. And we're so stringent that what we really worry about on slicers is in these delis where you go to the grocery store and they use the same little plastic thing on their hands, and they wipe this and they wipe this, and then they touch your meat, and those, they don't clean their blades. And so the real risk in some of these cold cuts is because of the way that they're doing them. So don't think you have to do everything. Steam cold cuts back, and again, if you're having trouble with them, be careful with them.
And then just like Maryann said, for most of our NET folks who are not on chemo, which is majority of our low-grade patients, we don't have to worry about it, everything in moderation. All right, getting back, I have a question for Rachel. What are your thoughts on food supplements, nutrition supplements, and vitamins? Do our patients need those? And if yes, what kind? If no, I guess that's fine then.
Typically, the only thing that I recommend is a multivitamin to kind of cover maybe the things that we're not getting or able to get in our diets. Some of the vitamins do need replaced. For example, after certain surgeries, and you're not able to absorb those medications, vitamins, and minerals that have, if you've had part of your intestines removed. Vitamin D and calcium are a little bit different because that's something that a lot of us need to supplement as we age anyway. Unless there's a truly identified deficiency, we don't recommend, excessive high levels or doses of vitamins and minerals. Antioxidants are great. They're great from food, and sometimes we caution with excessive high doses, like 1,000% of the daily value. More is not better in this case because a lot of times, one, we don't know how it may interact with your therapy. Two, whether it can kind of contradict some of those treatments, especially with radiation medicine. So we do caution on some of those. And some of them, may be just not absorbed, and you're spending money on something because you want to zero in on something you think might be an issue. So always talk to somebody about that if you're considering those types of things.
Wonderful. I think we have one final Q&A session, but I would like to wrap up our panel discussion by asking all of the panelists some of the thoughts that you want our community, your patients, caregivers to take home. So key take-home messages, especially Leanne, you have a wealth of knowledge. And although you say this is your last one, I have to see.
I'm tired. This morning I was so tired and so homesick.
We'll get you back again.
And I'm from right above New Orleans, but I got a sweet message. I got a flight out tonight, which I never planned on doing. And he sent me a message and said, I got a pot of gumbo on. I'll be here when you get here. So I'm good now. So the takeoff message is prepare ahead. If you try to make decisions about meals at the time of the meals, then it's a panic. If you can plan ahead and just kind of write it down, take the time to write down about what you're going to eat. Usually everybody eats about the same things every 3 to 4 days. We really kind of repeat, even among everybody, not this population, everybody, about every 3 or 4 days. Write you out some menus. This is also very helpful when you have people from churches that want to bring you things, and caregivers and people from outside, so that they'll know what you can eat and what you can. So take time to prepare ahead. Don't get in a last-minute decision, because I can tell you that if you want to eat baked foods and then you run by a fried chicken place in South Louisiana, you're going to turn into the fried chicken place. So don't get yourself hungry before you make those decisions.
Rachel, you want to go next?
Yeah. I think part of what I've take home for me is that you're doing the best that you can, and you have permission to make this part a little easier on yourself. And so I do think the preparation is excellent. Recording things, you have to listen to your body, but because what bothers you may not bother someone else. I have a person that can eat a less or more green banana, and somebody can't eat one that's more ripe. So focus on the things that do work, because it's very easy to get caught in I can't do this, and then it becomes I can't eat anything, because that's not true. So write down what works. Write down what works that day and keep a list. And don't get discouraged, because while it takes some time and some frustration and trial and error, we can help you find what's going to work for you.
It might take away. So I have so many. But one thing is that you also have to remember that there are other factors besides the food that you eat that can cause the diarrhea. So what might cause a lot of issues once may not cause any issues the next time. And then you might eat it 3 weeks later and you go again. Be prepared. You know, if you have to, make sure you have Imodium with you, make sure you know where are the bathrooms. How many people knows where every bathroom is in Walmart, shopping, Target, or wherever? I can tell you every bathroom from New York to South Carolina on the highway. Aman laughs at me.
No, this reminds me, somebody actually gave me a pointer. Is it called Bart's or something? Buc-ee's. Buc-ee's has, you know, if you need one, it's the cleanest bathrooms. They have like 40 of them. They clean it after every use. So thanks, I was just sharing the wealth.
Also Cracker Barrel.
I don't own their shares.
Cracker Barrel actually has a map that you can follow along. But, you know, just remember that if you're traveling and stuff, just be prepared. You know, if you know that you're going to go out to eat, make sure you know, use caution when you go out. But things like that. One thing that is a big tip that I learned when I got diagnosed was that a lot of us get really, really raw butt after so much diarrhea. And it burns, and it swells, and it's red. This is going to sound crazy, but I swear that this works. I want everybody to go, when this happens, have it in the refrigerator, go to the store, buy yourself a bottle of milk of magnesia. Stick it in the refrigerator, and if that happens, pat your butt with it and let it dry, and it stops the burning and it takes the inflammation out. I learned this from a nurse who was an OB nurse, and so they used to use it on the episiotomies and things like that. And she told me that, and at first I was like, are you crazy? And she said, no, it actually works. So I have a bottle in my refrigerator at all times, and it's marked, Maryann, do not touch.
So you've heard about Boudreaux's butt paste, right?
Yes, that's true.
I'm a new dad, so I'm kind of getting used to that stuff. So maybe you can patent this. This could be Maryann's butt cocktail.
There you go.
We've had quite a few cocktails. Another one is we do when we haven't spoken. I want to say this. Many times you need a medication to digest. And your doctors may have prescribed you pancreatic enzymes for pancreatic insufficiency, especially if you have fat malabsorption. Floaty foul stool smells really, really bad no matter what you do. So if they've ordered you that, make sure that you know how to take it and take it accordingly. Because you're going to have, and same thing, some of you may have not, many of you have your gallbladder taken out. Me too. Okay? So some of us just have a bile. You know, you have bile, B-I-L-E. That's one of those words that I don't do very well with. And so you have to, you know, there's medicines that help bind the bile, and those things can really be life-changing. What made me think of it is because we used to even take aqua, you know, the water lotions, and put the cholestyramine in the aqua lotions and use those on your bottom. You can get a pharmacist to do it. You don't have to mix it at home. But those things even on the bottoms can even work. If you're having a lot of burning, just stinging burning, a lot of time it is that bile because it's really hard on your rectum. So be sure and tell your physicians if you're having those things because they can really help you out with this. We have aids. We have medicine to really aid in digestion. So that really makes a difference.
And the final concluding take-home message from me as a provider, sometime in our world, things get so busy with assessing for treatment toxicities or scans, and sometimes we forget about this very important aspect. So please remind the doctors, how is your bowels doing? How are your nutrition? That it really is important to us. Just because we forgot to ask remind us. I'm guilty of that. Sometimes I forget about that. But it is really important. Nutrition is a very important part. We can at least involve our colleagues, nutritionists, and delegate some of these duties because this is really important. I think with that, I'd like to conclude.